So good evening, everyone. I welcome you all to this very interesting session from Wincars for e-class teaching. So today we are going to have the dissection of a heart, which Dr. Nishchal is going to elaborate. So I welcome to this program Dr. Jyotsna Madhuri. She is one of our chairpersons and she is the founder of Wincars. Welcome, ma'am, and thank you so much for joining us today. And I welcome Dr. Nishchal Pandya. He's assistant professor of cardiothoracic surgery in Sri Jayadeva Institute of Cardiovascular Sciences and Research, Bangalore. And thank you so much for giving us, the viewing of your dissection and the explanation also. Welcome to our forum.
Thank you, sir.
And I also welcome Dr. Deepa S. Kumar. She's additional professor of cardiology in Sri Chitra Tirunal Institute of Medical Sciences and Research, and she'll be joining us shortly. So Dr. Usha will also be joining us in a few minutes, and I welcome all of you to this forum. And a few questions before we actually go into it. Dr. Nishchal, just wanted to ask you, how did you, what kind of a heart is this, and what are you showing us today?
Yeah, so this is basically a porcine heart, very similar to the adult human heart, and with a few changes here and there. I'll try and elaborate at a few places. So what we have tried to do is try to explain the external morphology and then the morphology within, sticking to the basics. And let's see how it goes from there.
Dr. Deepa is additional professor of cardiology at Sri Chitra Institute. Dr. Nishchal is assistant professor of cardiothoracic surgery. I welcome you all. Jyotsna madam, welcome to you too. I think Dr. Indra, our resident, will present the show the presentation along with the echo images. Indra, can you start? Dr. Nishchal.
According to the echo and according to the gross dissection, do you find a lot of difference in what you see in echo compared to when you actually see the actual heart while doing the surgeries?
So actually, yeah, so echo, what we are seeing basically is the 2D picture, no three-dimensional depth perception there. And many times, especially when we see the interatrial septum, the interventricular septum, when you see the PAs, MAPCAs at different points, there you have to use a lot of imagination, and over time we get used to where this VSD is, where that muscular VSD is, where the inlet is. So there definitely, yes, there's a lot of difference between just an echo, a still image of an echo. Again, the moving image is so much better. So that's why we always sit down together and see the echoes before we go in.
So have you had surprises when you actually thought the AST was much smaller, and when you opened up and you saw the AST widen up in some different three-dimensional view when you did the surgery? And which rim do you think is very important for us when we try to go ahead with the device closure for such patients?
So I think in ASDs, if we talk about ASD, whatever we see on an echo, that 2D picture, in my mind, think it'll always be 1.5 times bigger than that. And that is what I've seen. Any of the shunts as in the ASD or the VSD, the septal shunts. So if you say like a 4/6, it'll end up much bigger. It'll be like an 8/6, or when we finally measure, because at the end of it, on a flaccid heart, it is again stretchable, and the ASD rims can stretch, as much. Coming to the rims, I think most important for you would be the posterior rim, the inferior rim, because anteriorly you will always find a rim, except, superiorly. Anteriorly, yes, the rims usually are thick, but the inferior, the IVC portion and the posterior portion, where we
those rims, they are quite important for us,
those are they're almost always very flimsy. If you say that it is not possible, and when we see it, many times the IVC is either totally deficient, and that would be it's like impossible to let it sit over there. And the posterior,
those would be the failed ones that come to you after we do try and
I have not so many, frankly, but yes, when you tell me that this is not suitable for an ASD, and when I see it, I see that yes, the IVC deficiency definitely is a
Main thing, right? Okay. Yeah. So are we ready, Dr. Deepa?
no, don't.
Yeah, before
Yes.
the Deepa starts presenting, just I have another question. Do you think that the 3D as a bedside evaluation for the intervention is an improved our outcomes? So also, do you think that so for the cardiothoracic component also? And the second one is there is a virtual printing is available with the images of the heart in the different dimensions. What is the implication of that for your surgery?
Definitely, madam. 3D, when we look at, if we just looking at 3D echoes itself, to get a idea about the valves, especially the mitral and the aortic, we try and look at those to let us know at what position, what is, try and turn them around. The AV canals at times to turn them around, flip them around, and see what is under. Again, it's a little limited. 3D printing definitely, yes, it's gone way ahead for us and has helped us a lot in these DORVs that are with remote VSDs, difficult septations. Does it have straddling that is significant or not? To look at that, yes, they definitely help. So yes, I would say that is a big key factor. The problem is the cost with the 3D printing. So if we can get that down, it will help many more people in septation, I'm sure.
I think Deepa is ready.
I was ready before itself, ma'am. I was just
Oh,
waiting.
sorry. I thought.
No.
Please go ahead. Please go ahead.
Indra,
Indra?
can you start?
Yeah.
Sorry for the technical issues. Usually the confusion for us with the surgeons is the VSD. And surgeons are not happy when we say upper muscular VSD or lower muscular VSD. How would you like the VSDs to be classified as per echo so that it correlates with on-table anatomy?
So VSD is what we say when you say upper and lower. Mostly we are looking at either inlet, anterior, or are we looking at something more apical? So for
Whatever
us,
is below the perimembranous region,
yes,
just below the perimembranous region but bordered by muscle. We
yeah.
tend to call it as upper muscular because in the septum it seems to be high up when we see in a 4-chamber view or a 5-chamber view.
Yeah.
So how would you call that VSD as?
So I would call that as a inlet muscular VSD because it's in the
It's
inlet
beneath
portion.
the aortic valve. I mean, but there's a muscular rim, but it's beneath the aortic valve. It's just
So
below the perimembranous region.
yes, so then two things. If it's just beneath, if it's that VSD beneath the aortic valve in the muscular, it's an outlet muscular. If it's below the tricuspid in the upper part of the muscular septum but posterior, it becomes an inlet muscular.
In
Anything,
between,
sorry?
in between, like in the perimembranous region, just beneath the
Yes.
perimembranous region.
So just beneath perimembranous, but again, are you looking at the aortic valve opening or are you looking at the tricuspid opening? When you look at it and you see the aortic opening, I would call that as an outlet muscular. And if I'm seeing the tricuspid valve in that shot, then it will be an inlet muscular.
Okay.
I think surgeons
Yeah, Deepa, your views.
Right.
Is your presentation ready, Indra? Is it
Yes,
working?
it's an anterior muscular VSD. And if you see the inflow, you're supposed to say it's a posterior muscular VSD with inflow extension. I mean, am I audible? Yeah.
Yeah, audible, Deepa.
I just wanted to ask one question before we start. Do you find this pulmonary vein injuries when we've done a RUPV approach, we try to put a device through the RUPV, right up a pulmonary vein, and we don't succeed and we send for surgery. Do you find this RUPV or LUPV injuries during surgery?
I've taken out one device. I have not seen injury over there. Luckily, that device has just flopped down and migrated down. So I didn't see injury there. But definitely where it has flopped down and gone into the RA, the rim, that has gone and caused a little hematoma around the RA, but nothing of dramatic consequence.
So this is the gross anatomy of the heart. It's a porcine heart, very similar to the human. What we see is the anatomical or the Valentine approach is how we usually describe it. So you see the heart standing on its apex, the two atria, the right and the left atria, the right ventricle and the left ventricle. So these are superior, these are inferior, and this is the apex. The heart in its position in the thoracic cavity is nowhere like this. It actually is this way, right? So you actually have, it's a conical structure with a base posteriorly. It has a sternocostal anterior surface, a diaphragmatic surface, a lateral surface. Okay. Now, looking at the external morphology, here what we see is very clearly okay. Right. So
external morphology of the heart. And this is how we see it in all the diagrams, the real heart shaped. It's a Valentine approach. So you see the two, the right and left atria, the right and left ventricle. But what we see in the heart, in the chest, and when we look at it, is this way. I think it's inverted right, left. But for the surgeon, it's more lying down with the apex away, the right anteriorly and the left posteriorly, rather than right and left.
right. So this is the gross anatomy of the heart. It's a porcine heart, very similar to.
So the echo, as we see, this is the apical four-chamber view, which we routinely start with. So this is your right atrium, the right ventricle, left atrium, and the left ventricle, which is seen when we put the probe in the cardiac apex.
Very clearly, the right atrium, the right ventricle, the left anterior descending, which divides the RV and the LV. The RV outflow.
Can you make it big, Indra?
Now coming to it, step by step.
That is very small.
Yeah.
1 second.
Very clearly, the right atrium.
Are you able to hear this?
The left anterior descending, which divides the RV.
Yes, soft, not loud.
The RV outflow, the pulmonary artery, the aorta. Now coming to it, step by step. This is the right atrium.
Yeah, so this is the right atrium that has been opened, and the probe is going into the IVC. The rough portion that you see above is the trabeculated portion there. And you can see the C that is with the convexity to the right. Now that is what we are showing. Right there is the sinus venosus, smooth portion, the back wall of it. This is the anterior, the upper trabeculated portion, the crista terminalis with all the pectinate muscles going right up to the RA appendage. The sulcus terminalis is not clear in this because it's very thick in the postmortem specimen. But if you see the crista from inside goes right up to the SVC, that's what we are showing there. And that's the outside of the SVC, and that is where the SA node sits. So it's on the medial side of the SVC-RA junction with the sinoatrial artery going over there. Now I'm trying to find out, yeah. So
This meeting is being recorded.
So the echo portion back to Indra. So
So what we are focusing on here is the right atrium, along with the tricuspid valve, and then which is entering the right ventricle. The crista terminalis, which sir mentioned, is very faintly seen here. And these are our routine bicaval, subcostal bicaval views. And this is the interatrial septum which we see here. And this is the SVC seen draining into the interatrial, into the right atrium. And this is the IVC draining into the right atrium. This is the interatrial septum dividing the right atrium and the left atrium. And in this image, we can see that there is a fossa ovalis, patent fossa ovalis. There is a flap seen here, and this along the in the mid of the interatrial septum. And one more structure which we see here is the eustachian valve at the joining at the portion where IVC is seen joining the right atrium.
So coming to the ventricular part, again, coming to the RV. The RV has this tripartite, or it has three parts. The inflow, so that's the apex portion, the outflow, and the inflow. That's why it's a tripartite RV, and that's where the tricuspid valve sits internally. Now looking at the pulmonary outflow over there, the right and left main pulmonary artery going to the right that I'm showing, and to the right. Sorry, is that not playing? Yeah, so this, if you can see, this is where there's the atrium, ventricle, the groove, AV groove, and that is where the tricuspid valve would sit. This is where the RCA would come with the acute marginal branches. This is basically the inflow. This portion would be the apex, and that portion would be the outflow. So three parts there. Again, this is where the pulmonary valve looks like it would sit, because this is the veno-arterial junction, but the valve is always 4 to 5 mm below, and this is where the actual pulmonary valve would be sitting. The pulmonary artery again goes up, divides into the right and left pulmonary arteries, and with the ductus communication there.
Moving on to the echo correlation, this is our standard PSAX view where we can see the right ventricle. This is the right atrium with the inflow into the right ventricle, that is the tricuspid valve seen. And tricuspid, the RVOT, and then the pulmonary valve is visualized, which then opens into the pulmonary artery. The three structures are seen around the aorta. This is the short axis of the heart. And this is a similar subcostal short axis view where we are able to see the aorta and the aortic valve in the center, and the right atrium opening into the right ventricle through the tricuspid valve, and then the RVOT, followed by which there is the pulmonary valve, and the pulmonary artery origin is seen here. Actually, you had explained PDA in that set, if you want to tell. And this is a view to see the ductal attachment to the pulmonary artery. So this is the PDA which is seen attached to the pulmonary artery in the standard ductal view.
This is the septal leaflet of the tricuspid. So coming to the tricuspid valve, the inflow region, we see the septal leaflet, the anterior leaflet, the posterior leaflet there. Yeah. Now here, as we look up, and yeah, so the portion that we see coming just below the inflow and the septal leaflet, this will form the triangle. So that's your coronary, that's the RA, very thick, and it looks more like a muscle itself. Your coronary sinus there, and tendon of Todaro would be seen somewhere here. Again, it's more, it's seen clearly when we pull the heart, not so much in this. The apex or the triangle of Koch here, this would be the triangle there. And where the apex sits, there's usually a small vein, and that is where the AV node would sit. Under that is the septal leaflet. So again, when we are taking our bites, we try not to go more than half of this region, and we try not to come to this beyond the anteroseptal region into the septum. So that is your three leaflets there: the septal, the anterior large, and the posterior leaflet there.
So in our routine four-chamber view, we will be able to see the anterior and septal tricuspid leaflet. This is a modified parasternal short axis view where we are able to see all three leaflets. The septal tricuspid leaflet, the posterior and the anterior tricuspid leaflets are seen in this image.
So if I can put in a word, I think there are residents listening in. Am I audible?
Yes,
Yes.
Deepa. Yeah.
So, usually when we report on Epstein's anomaly, we are not sure whether we are seeing the septal leaflet or the tricuspid leaflet. So usually we say that it is a septal leaflet that is apically displaced, but most often we find that the posterior leaflet is also apically displaced. So when we want to give a report to the surgeon, we have to comment on all three leaflets. Of course, we comment on whether the ATL is tethered, whether it is large and sail-like and freely moving, or whether that is also looking dysplastic, and which leaflet is more apically displaced, whether we do have a good STL or a PTL. So what we usually do is quite simply, in an apical four-chamber view, if you see the coronary sinus, the leaflet that you're seeing close to the septum is usually the posterior leaflet. And when you take your probe a little anteriorly and you see the proper four-chamber view without seeing the coronary sinus, that leaflet is attached to the septum is usually the septal leaflet. I don't know if the surgeon shares the same.
Yeah, very true. Because as we go behind towards the coronary sinus is where the posterior starts, and that's what we see. And the septum is definitely a little more anterior to the coronary sinus in that portion. Yes, so it actually really helps. But most of the times it's the septo-posterior that's not delaminated and stuck and displaced downwards. Shall we continue? So that's looking at. Okay, now that's opening the RV up. We made a lateral incision, a medial and a lateral incision. So if you see this, the convexity here and a concavity over here. That convexity is actually of the LV there that is bulging into the RV, and that's why you see it as a banana-shaped structure. Coarsely trabeculated RV over here, you see, it's not so coarse in this specimen. And then you see the TSM there that comes along downwards. Now, if as it comes on, it's been cut from there. But the ATL, papillary muscle to the ATL comes off from this TSM. And there are usually a lot of chordae that go off from there. The classical hallmark, as you all know, is this septal muscle, the muscle of Lancisi and or muscle of Luschka, and that gives off your septal chordae. That is important for us because till that point, we try and keep away from the crest when closing the VSDs so that we don't get into conduction problems.
So can you just elaborate how is the conduction bundle related to that papillary muscle?
So now if we look at this, this is the inlet. We are looking at it sitting in the RV. This is the septal leaflet. This would be the anterior leaflet. And this is the posterior leaflet below my thumb. So as we come in here, now above the septal leaflet, somewhere midway 1/3 to 2/3 towards the anterior leaflet point is where the AV node would sit. And then goes in there as the bundle of his. When you have a perimembranous defect, it's in this area. So this would be basically deficient without muscle. And the point where the septum and this portion of the muscle attaches, that point right there under that septal leaflet is our danger pinch point. So we want to avoid that. That is one. The other points are as the VSD extends like this, the margin. So if you think that this is the crest, till somewhere here, just along the crest are our bundles again. So the right bundle, and we try and keep away from here. So we take sutures that come off somewhere here. If the margin is here, we're at least 5 mm away from it, and the patch sits on the RV surface.
Dr. Nischal, can you also show how the hypertrophic bundles are seen in TOF in this specimen?
Yeah, I think it's just coming up next. Let's see. Let me... Okay, I think it's there in the next video. But when you... Yeah, so when you see this, I basically opened up the RV like that. And if you try and put it together, I try to do that and we'll see if that works. But this part of the RV, if you think of it as a book that has been opened, that would be this part of it. Yeah, there, right? So that area is where your parietal, that is these bundles that are very thickened in a TOF specimen would be. And that comes back to the septum over here. So the lateral part of that would be the septal leaflets. So you have 2 points, one laterally, one anteriorly, that are actually thickened. So these fine, more or less courses, little fine, they're not so coarse here in this, but these trabeculae that are seen will be very thick with deep recesses in a hypertrophied heart. So this is your parietal band basically. So when it comes over, it is sitting on the anterior. If this is your cavity, these on the inner surface, it is all rough over there with thickened muscle with lot of crevices in there. And that muscle we cut, and that is the parietal bands that we cut, and the septal on more medially to that. And the infundibulum, if you see, many times the infundibulum itself is very thickened. So at times we just slice part of this infundibulum partly to try and get a more wider cavity there.
So how is it different when you have a double chambered right ventricle and sometimes you have a os infundibular pulmonary stenosis and then you have the regular subvalvular PS of tetralogy fallow. So how is it different in this?
So coming to, yeah, sure. Coming to TOF, it is these muscle bundles that they are well away, at least 5 mm to a centimeter below the os. Yeah. The muscle bundles are below the pulmonary artery opening. So the muscle bundles are thickened, but we also see a distinct fibrous ring. So that ring, as we cut, the muscle bundles come into view and we keep cutting them. That is, and this is well above the infundibular septum. That is your TOF. When we look, so if this is the infundibular septum, you'll see it beyond it. Well away from the margin of the upper margin of the VSD as well. When we see a double chamber right ventricle, this gets shifted more at this point. So it's more actually in the center itself, and we still see an os, but it's closer to the papillary muscle that comes off from the TSM somewhere here. So we are seeing a thickening over here, somewhere at the midpoint of the VSD level, not so far off. In just pulmonary stenosis, if it's going to be a fibrous os, again, it'll be more at this far off infundibulum area. And it's basically annular stenosis, or then we look at the valve and things like that. So those are the points. So proximal, somewhere near the midpoint of the VSD, in the middle of the septum is the DCRV. More distally beyond the infundibulum is where we see the TOF hypertrophied muscles.
Nothing else. This is the right ventricle seen here. the tricuspid valve leading to the right ventricle, and this is the moderator band which is seen in the cavity of the right ventricle. So the inflow part and the apical portion of the right ventricle are seen in this view.
So here again, if you see, cut this section and view it, transfer in a cross section. This will be like a banana, and yes, this will be like a circle. So that's what we are seeing here. This is the right ventricular part of that LV bulge that we look at over here. Yeah. Now, if you notice here, the PA. So this is me trying to explain, how I was opening. Now here, if we can just stop it a bit. Yeah. So if you saw that, it was closed. If my tips of the fingers are this point, yeah, this is the septum. That is the LAD on the surface. So this is the infundibulum or the conus. This is the pulmonary valve. Now we've opened this up. So when I've cut through across the pulmonary valve into the pulmonary artery, this area that you see, this concentric area, yeah, the bundles on this end, which get thickened and compress anteroposteriorly or narrow it anteroposteriorly, are the parietal bundles, which we just split across, cut them. They are not like going across into the cavity, but they are more just on the wall of the cavity. And that's where we cut them and slice them off and reduce the chunk of muscle there. Whereas the portion that comes onto the septal area over here, a little more dangerous part, this is your septal leaflet, the septal bands. Again, at this point will be the ones that go to the conus and the conus septum again. So these would be thickened. These would be another set of septal bands that we sometimes have to cut. Here we have to be more careful, because if we cut into these too deeply, we would go right into the LV. The conus area, as I told you, would be thickened at times. So we just sometimes end up shaving this bit off sometimes. So when we look at it from inside, if it can be seen here, so the septoparietal area is there, yeah, and the parietal bands coming there. Septal defects, if we see. So here going about septal defects. Now this is the septal leaflet, muscle of Lancisi. Oops, shaking a bit. This is the anterior leaflet, and this is the posterior tricuspid leaflet. This is your clear-cut septal region. Now just under this, let it run a little. Okay, so if you look at this again at this point, where the scissors are going, this is more into an inlet posterior area. But at this point, when we look at, there's a whitish perimembranous region, and the PMVSDs would be at this point. If it's going to be a posterior, so this we would call it the inlet portion, this much of it. This entire thing would be the trabecular portion encompassing all of this. So this would be my posterior inlet, posterior muscular VSD, or the inlet muscular VSD. These would be your trabecular muscular VSDs. The apical muscular VSDs would come more over there. The outlet muscular VSDs are around here. And when we go to the conal part, Again, if it's just under this, they would be the outlet VSDs. This the defect that comes right here. So that point exactly, if you see that little whitish structure there, that is your perimembranous portion.
So echo-wise, an inlet VSD is usually seen in the routine four-chamber view, where once the two valves are atrioventricular valves are open, and the VSD is usually situated in this region. A perimembranous VSD is usually seen with a slight anterior tilt of the probe, where once the aorta is opened with an apical five-chamber view, and we can see a defect in the perimembranous region. This is the restrictive perimembranous VSD seen here, just below the aortic valve. And this is a muscular VSD, mid to apical muscular VSD seen here. Another view to see the muscular VSDs is ventricular short axis view, where the anterior muscular VSD, mid and posterior muscular VSDs can be appreciated. And this is a patient with TOF, and this is the routine outlet or the conoventricular VSD, which we appreciate in tetralogy of valve.
Anything about the supraventricular oh. So again, coming to this portion, the conus is always a bit of a confusion for all of us. I mean, single conus, where does it lie? Where is it coming? How is it oriented? Basically, the TSM goes on with this thickened muscular band, and that is your supraventricular crest. And that band above will encompass the conus as well. So things that come out into this region, when there's a defect, you're not going to see that clearly at all. But when it comes here, it is lying more under the aortic valve, and that would be your outlet supracrystal subaortic defects. When it tends to come closer to the pulmonary valve over here, as you see, the defect is here, you're going to see a subpulmonic defect. Anything in between here will be doubly committed, and many times, it looks like a doubly it looks like subpulmonic or just a subaortic with an outlet extension. But then we see both these, the aortic and the pulmonary, are sharing a common annulus, and many times they're doubly committed. So our suture lines would then have to lie in between that. So that is your outlet, the supracrystal defects. Now coming to the pulmonary artery part of it. So cutting open into the PA, as I told you earlier, that's your main pulmonary artery, ventricular arterial junction. But you look here, this is where the annulus actually sits, well below. This is at least 5 to 7 mm below the VA junction. So that is quite distinct there. So whenever we're making our cuts, in a cono, we need to be mindful of this portion especially. And when we are doing a ROS, we go well below this. And again, the septum or the first septal would trouble us there. Now that is the right PA or the right pulmonary artery. The ductus is not clearly seen here, but this is the right PA, and the opening is gone on to the left pulmonary artery.
So as we see, we can see the RVOT and the pulmonary valve here, which opens into the pulmonary artery, which is dividing into the left and the right pulmonary artery here.
So when you tell me about subpulmonic, subaortic, and doubly committed VSDs, as we would see in this view, when I see something here, I know this is subaortic from that 9 to 10, 11 o'clock. Anything between 10 to 2, I know is going to be between the two and doubly committed. If it is solely after 2 to 3, then it's going to be subpulmonic. Again, just in this view, it will be a little hard to say. If there's going to be muscular extension, it would well come under the subaortic region as well. Now here that we see, you're seeing the valve area. This valve area, as I depicted in the slide here, in this. So just trying to play this. So you see that valve, which is there and coming off at the cut portion basically. And if you go back to the echo over here, that area, that is what we are seeing. So we are actually seeing you're going into the RVOT muscle area, and we are looking at the valve hinge points there. Again, the outlet area in TOF, we want to know how thick it is, how far it lies. And this is where you will see your thickened bundles classically. In a double chamber, when we open and see it, when the bundle lies here, that is where it will be a double chamber right ventricle. And another thing, sorry.
So, yeah. No, I was just telling it, this view is very, very important, especially in tetralogy of fallow, because we can describe the kind of VSD. So as you said, 9 to 11 o'clock position, it is a subroutine, subaortic VSD that we find in tetralogy of fallow. And we find that it is closely related to the RCC, NCC commissure. And if it is, and another thing is in Asians, we find that doubly committed VSD is slightly more than in the Western population. So we have to inform the surgeon if it is a doubly committed VSD, which extends, as you said, to maybe from 12 o'clock to 2 o'clock position. Basically, looks like a very large VSD with hardly any infundibular muscle. And we have, of course, have to look for the infundibular stenosis in this view. And another very important thing for the residents is we have to look at the conal branch crossing right ventricular outflow tract. So two things we have to see. We have to see if there is actually an LAD from the left sinus, and if there is a very large conal branch from the RVOT. If there is no LAD from the left sinus, it is probably LAD from RC. If there is a LAD as well as a large conal branch, it could very well be a dual LAD. And we always have to say how far the LAD, the conal branch is away from the annulus. So this view is very, very important in tetralogy of fallow.
Right. So typically, this is where that conal branch would lie, coming just over here. And if it's a dual LAD or just an LAD from the RCA, this is where we would see it. And yes, very important for us because we want to know how far this is, especially if it's not a valve sparing TOF, it's going to be a tap and things like that. Then it would, decision making depends on that.
Just one doubt, would you call it an outflow muscular VSD if the VSD is between 10 o'clock and 12 o'clock position maybe, or somewhere in the 12 o'clock zone?
10 and 12 here in this view.
Yes, yes.
I would still not call it an outflow muscular because we are now above that supracrystal area. We are well into the conus. So, and it's right under the, it's in the outlet region. So not muscular typically, but again, when you open up and see another view and you're looking at this and you see it extending down, then you could term it at that. But in this view, if it's just a defect here, I wouldn't be so bold to call it that.
Dr. Nischal, if there is a doubly committed VSD, would you open both RA and pulmonary artery to close the VSD?
No, I've gotten away always with just the RA approach because the VSD that we see, as I see, both of it share a common, the pulmonary artery and the aorta, which are side by side like this, share a common annulus. So it's just taking a few non-pleated sutures in that common annulus, and it's still very doable from the RA side. If it is going well under the subpulmonic, then yes, I would open up the pulmonary artery to close it. And a few bites would come from the supravalvular pulmonary artery, into that region. Or again, where we create a subpulmonic defect, make an outlet into a subpulmonic defect, is when you have a TOF with a restrictive VSD, a DORV with a restrictive VSD, and we know that this is going to cause LVOT, then we literally cut under the subpulmonary area, and that area would be repaired again from the subpulmonary area if it's too far off.
Okay. Okay. And suppose there is a perimembranous VST with an RCC prolapse, and you have to resuspend the aortic cusp. So for that, what would be the approach?
So RCC prolapse, again, mild, again, 1, 2, 3, 4, or trivial, mild, moderate, severe. Mild, moderate, trivial, mild, even up to moderate. If I see the cusp, it's prolapsing. When we patch that upper portion, it sort of suspends itself over there. Sometimes you've had to go in from the aorta, if that cusp is actually elongated, go in from the aorta and take a few bites supravalvar and fix it over there. So that would resuspend the cusp again into the aorta, would shorten the leaflet as well. And if it's severely regurgitating, then we'd probably put some commissural sutures as well and make the cuspal height a little shorter.
Okay. Okay.
So, yeah, the next one here, let's see. LA. Open the LA and see. Going into the LA appendage. So that's the left atrial appendage now that we've come to, the left-sided structures. Yeah. So you see the trabeculated portion again over here, but most of it here is the smooth portion there. And this little part, I think pulmonary valves are not very clear over here. But then this portion here is that LA appendage here. See how close it is to the circumflex. Now the circumflex artery is just around here, that one. The LA appendage itself is smooth in most of its part, the base of the LA appendage, sorry, and from where it starts, it gets trabeculated. Yeah. Behind posteriorly, you would find the pulmonary veins.
This is a P-sax view. From with a little posterior tilt, we will be able to see the left atrial appendage from the routine P-sax view. And the significance in for us is presence of clot or thrombus in the LA appendage can be ruled out, or more preferably TE is used for that.
So when we look at it, the type of appendage is finger-like and broad, thin, narrow, and long. Again, we are interested in the external morphology. When we open up and see the right side looking like an RA, then yes, you know, it's a left atrial isomerism. We want to know if there are clots in the LA. It is important to know how big that LA actually is for TAPVCs, and especially our supracardiac TAPVCs, because the cut would go into the LA appendage, unlike an infracardiac where it would come onto the body more or so. So those are the little implications for us. Now coming to the mitral valve over here, it's basically an inverted bishop's mitre, and that's why it's a mitral valve. So you have the anterior and posterior posteromedial papillary muscles, leaflets. Yeah. So looking at the cavity there, that is the circumflex artery. I think it may be the vein accompanying it. I mean, the part of the great cardiac, but the circumflex artery is right over there as well. Now the chordae again, so you have an anterior an anterior leaflet, posterior leaflet. Yeah. So you see all the leaflets now. This leaflet portion, when you look at that, you see the attachments going to the edge of the leaflet, and these are two thick fan-like chordae, which are the primary or the strut chordae. vary anywhere between 3 to 13 in number, including the primary chordae. The secondary chordae are those which come off again from the wall, but don't attach necessarily to the edge, but back into the body of the leaflet. And the tertiary chordae are something like this, like going from ventricle to ventricle, like muscle to muscle, papillary muscle to the wall itself. Not of much importance again over there, but when we are doing a mitral valve replacement, we like to still keep these chordae along, try and preserve as much as we can, and try and keep the basal or the tertiary chordae in portions of the posterior mitral leaflet.
So this is the ventricular short axis view where we are seeing the papillary muscles. This is the anterolateral and the posteromedial papillary muscle seen in this view. And this is the short axis of the mitral valve seen. And this is the anterior mitral leaflet. This is the posterior mitral leaflet with the three parts A1, A2 and A3. And P1, P2 and P3 are visualized. And this is the plaques view to show the mitral valve and the aortic valve. And we can see the aortomitral continuity in this image.
If anybody in the audience want any clarifications or anything to be specifically demonstrated again, please type your request in question answer box. We have a cardiac and a model on which we can demonstrate. Dr. Nischal will show you.
Nischal, one question.
Yes.
Will you be showing aortomitral continuity here?
Yeah, it's coming. Yeah.
Yeah, sure. Okay.
Okay. Now, find the calculated LV and the outflow tract. This is the aortic valve and aorta which has been splayed open. So you see the aortomitral continuity. Now, I don't know, could you get that? So if we look at this, basically, this is the anterior mitral leaflet that has been split and into the aorta, and the aorta is split as well over there. Looking at this, so this is the posterior leaflet, the LA over there, the PML, and this one anteriorly, if we can imagine it, is the anterior mitral leaflet or the AML. So the area over here, if you could, yeah, if you see that area, that's your aorta and that's your mitral continuing immediately, right? The other thing to note over here is, see, that little button over there and one more button there. So when we look at the aorta closed, this would be your left main coronary artery. That's the right coronary artery. So the LCC, the RCC, and the non-coronary cusp over there. Typically, this AML would, lie anywhere from half of the, if you see it here, somewhere half of that left coronary cusp up to the non-coronary cusp, half of it. The RCC is free, it is anterior. This again is your ventricular arterial junction. Clearly, when you look at it, similar to the pulmonary artery, it is well below the outer ventricular arterial. The valve sits well below that outer ventricular arterial junction again over here when you look at it inside. The portion between the right and the non-coronary cusp, this area is more fibrous. That is, and when you open it, you would go right into the RVOT. Again, the base at the nadir of the RCC at that area at this point is where the bundle lies. So we have to be careful when we're taking sutures there to be higher up over there. And I think the next one I've tried to demonstrate just a connection, when you go in from, so yeah, if you could see that, I'll try and play it again. Yeah. So this is the RA opened up again. the right atrium, the smooth portion. The limbus, unfortunately, the specimen didn't have a good limbus fossa ovalis and couldn't demonstrate the septum secundum and very clearly in this. But this is at the base of the SVC, the torus area. Torus aortic is when I actually put a needle through. It comes right out into the non-coronary cusp. So that is basically just part of the RSOV. So if you have an RSOV, normally you would see it under the right coronary cusp. But if it's going to be in the non-coronary cusp, it's going to open into the RA. And as we keep moving, it keeps going on from RA to RVOT to LVOT.
Maybe that's the point where if a ASD device perforation happens, I think
it would
probably
happen
that's why.
over there. Yes,
Yeah.
yes, ma'am. And if you're lucky, it goes high, you'd be away from the cusp. If it goes low, it would go into the annulus and the cusp.
Okay, I don't think there's anything lucky about having perforation. Two requests from the audience. They want to see VST again, subpulmonic VST and subaortic VST. And they want to see the position of the bands in DCRV. Can you show again, please? The slide where you had shown VST, Indra.
Yes, ma'am.
You show it, and then I'll show this.
Maybe in the model also they
Yeah.
may want to know.
Good idea.
Small reminder, we have to conclude in the next 15 minutes.
Our presentation is over, Hema, just answering the
Okay.
audience questions.
Okay.
Anything about the supraventricular outlet effects? Okay. So yeah, please. That's fine. That's okay. Okay. So let me get back again there. So as I told you, TSM, I didn't tell you about the anterior and posterior limbs. This is the posterior limb of the TSM. And this would be the anterior limb, which would cradle perimembranous outlet VSD again. This anterior limb, when you see, there would be sometimes a lot of smaller limbs and different versions that go on onto the free wall. And this area is the supraventricular crest area, or crista supraventricularis. So as I told you, above this area, this is the pulmonary artery. So anything below a defect in this area in the conus, above conal septum, above the supraventricular crest, but below the pulmonary artery is the subpulmonic defect. Let's see if we have the previous ones. Going on to the BA. When you see externally, there is a distinct ventricular arterial junction. So this is again opening the PA. If you see me, this is the closed RVOT, more towards the LV, that is the LED on the surface over there. So as we cut open that area into the pulmonary artery, yeah. Now this area, when it's actually closed, anteriorly would be the parietal bands and on the side would be the septal bands. So typically thickened bands over here that go to the septum or to the conus would be the septal bands, and the parietal bands are just on the roof of that RVOT. The double chamber, let me see. And
Can
in
you
this
show
view that you see, yeah,
in the
sorry.
model two? Model 2.
So if we look at the RV, not, you could see this. So this is the interior of the So the interior of the RV, not too typical over here again. We look at this area. So yeah, so that is your rough coarsely trabeculated RV and the outflow track that goes out over there. Now coming to the back of it, when you're looking into it, you can see this, I hope. Yeah. So that is your RV outflow under the pulmonary artery. So any VSD here would be a subpulmonic. Anything over here in this region would be a subaortic VSD. The bands, when you look at them, the bands are typically somewhere here, thickened bands in a TOF. Whereas in a DCRV, they are much lower down, somewhere over there. Yeah. And when we come to the echo, so when you look at this view, you would see a subaortic VSD in this portion, perimembranous extending to subaortic. Then between around 11 to 2 would be a doubly committed VSD when it's in this portion. Again, when it goes from 2 to 3, 4 o'clock, just under the pulmonary valve is your subpulmonic defect. Under the pulmonary valve, if you see thickening on that anterior wall, there's the RV outflow, anterior wall and the septum here. So this septal wall gets thickened in TOF to make it so narrow that it just blocks it off, or makes it like gets all thickened. It's all white over here, and this is your outflow. So those are your parietal bands basically. And on the surface there, you would see a conal branch, an LAD crossing, or a dual LAD and things like that. In a double chamber, you'd see the same branches somewhere here, if I'm right. Yeah. And that corresponds to somewhere at the mid portion of a perimembranous or a supracrystal subaortic defect. Yeah. Right.
Okay, thank you. One last question, if you can quickly answer that, and I think we can wind up the session. They want to know the rims of the AST. I think maybe in the model it would be seen better.
Yes. Right. Okay. You able to see that? Let me get oriented to this a little. Okay. So that's your fossa ovalis. Septum secundum closing it. Can we see that?
Yeah.
That's your SVC over there, and the IVC would be below. So for us, typically the superior, this is where the superior would like to have a pen. So that is where the superior rim would be. Now, as we come anteriorly this way, yeah, this part near the tricuspid valve. So that is your anterior rim. What is just above the IVC? This is your IVC rim and posterior rim over here. And if you see the posterior rim, many times you would see a posterior rim absent and you'll see HAPVD of these right-sided pulmonary veins, and they literally open into the RA under this defect. Yeah.
Thank you so much, Dr. Nischal, for taking the trouble for recording and joining us for the class. Dr. Deepa, any comments would you like to make?
It is really, really good. It is, I mean, it was explained so clearly. I'm sure all of the residents who attended must have benefited from it. I think most of the people were surgical because all the questions were surgical. So,
Thank you. Thank you for giving me this opportunity so much. And it's all, I mean, evolution over time, you sit and think and think and think, and then you start understanding why, where, what is coming from. And I hope this has made things a little more clear. I did not, if I can quickly just show the external anatomy of the coronaries, which I missed. Am I permitted?
I think
Yeah, we have 8 minutes. Yeah, yeah, missed 8 minutes. Yeah, maybe five, you can take 5, give us 3. Yes.
So I'll give you, once I get to that, I'll take 2 minutes. How do I get to that is the question.
Yes.
Yeah, first slide. No?
I also thank Dr. Indra. She has recorded very clear images and she's taken the trouble to split up the video and record at exact points. And this idea was actually given by Jyotsna madam to have a echo correlation. Otherwise, initial idea was to show only the gross anatomy.
So again, now coming to this, the first slide, I'm not sure if we could hear so much, but this is like literally, as I told you, the heart sitting this way, the right and the left. This is called the Valentine approach, because when you see this, it's that heart sign that we make always in diagrams. And that's how it looks, the two atria and the two ventricles with an LED in the center, but looking like one typical heart. So the LED lies just around between the right and the left. Anteriorly, you see the LED on the surface. It corresponds to the septum again over there. The LED has the great cardiac vein accompanying it. Posteriorly, okay, when we turn it around, so this is the cross anatomy of the heart. It's a cosine heart, very right. So again, the LED with diagonal branches. This is the obtuse margin of the heart, the lateral margin of the heart, and there are the circumflex branches. So the veins that go along these branches are the small cardiac veins. Posteriorly, it will all drain into the coronary sinus, and the posterior interventricular septum will have the little cardiac vein there. The other thing is, yeah, so that's about this. Again, when you see the acute margin of the heart over here, the ventricle doesn't have that much of a venous supply. So when we are actually venous, it more or less goes back into the RVS, the Bayesian veins. So when we are giving retrograde cardioplegia, this area suffers. And that's why, we'd like to give antegrade and retrograde. Yeah, I had some videos on it, but maybe next time we'll show those.
I think we've come to
Yeah.
the end of the session. Yeah. So I don't think we are seeing any more questions or in the chat box or in the question answer session box. Actually, I thank everyone here. I thank Dr. Usha for actively creating all this and putting things together. I thank Dr. Deepa. Thank you very much, ma'am, for your valuable inputs. I thank Dr. Indra. Really, your echo explanation has been very clear and crisp, and I thank you for all your efforts. And the main person who has dissected, I thank you so much, Dr. Nishchay. It's been amazing the way you have shown us all the anatomy, and I hope we can continue with such sessions in future, and hope to see you all soon in the next session next month. Thanks.
So next
Sure.
time, hopefully,
Thank you
we'll
so
have a
much.
smooth session.
Yeah.
Just
Yes.
yeah. Thank you. Thanks a lot.
Thank you.
Yeah.
Bye.
Thank you all. Bye then. Bye.